All right, let's pick back up and start with cretinism, now more appropriately referred to as congenital hypothyroidism. Same pathology, just less offensive terminology. This condition results from severe thyroid hormone deficiency during fetal life or early infancy. And this is a big deal because thyroid hormone is absolutely critical for brain development and skeletal growth. If it's missing during this narrow developmental window, the damage is permanent. Common causes include thyroid dysgenesis, which is absent or poorly formed gland, defects in hormone synthesis, and iodine deficiency, which is rare in the US, thank you to iodized salt. From a pathophysiology standpoint, low thyroid hormones lead to impaired neuronal maturation, delayed bone growth, and accumulation of glycosaminoglycans, which gives us myxedema even in infants. So, clinically, untreated patients show growth retardation, intellectual disability, hypotonia, which is aka the classic floppy baby syndrome. We have microglycia, which is enlarged tongue, because apparently even tongues aren't immune to the GAG buildup. So, key takeaway, and this is a big public health win, this condition is preventable. Newborn screening plus early thyroxine replacement can completely prevent permanent damage. Histologically, what you see reflects chronic hormone deficiency, not acute injury. Important distinction for us on the lab side. Now we jump to the adult counterpart, the myxedema, which is basically what happens when hypothyroidism is left unchecked long enough to wreak havoc. This is most commonly due to Hashimoto thyroiditis, but can also occur after thyroidectomy or radioactive iodine treatment. Pathophysiology here is simple, powerful. Decreased thyroid hormone equals decreased metabolism. And again, we see the glycosaminoglycan accumulation in connective tissue, or the GAG accumulation in connective tissue, which leads to non-pitting edema. Clinically, patients present with puffy face and periorbital edema, dry, coarse skin, cold intolerance, fatigue, and bradycardia. Everything slows down, even their kind of vibes. Now, from a histology perspective, this is where we come in. Increased ground substance in the dermis, widely spaced collagen fibers, edematous tissue without inflammation. And that last part matters. Myxedema looks dramatically clinically, but histologically it is not inflammatory. So key takeaway is myxedema reflects chronic metabolic dysfunction, not infection or immune attack, and histologic findings always require clinical correlation. This slide is our 30,000-foot view of thyroiditis. We're not diagnosing yet, we're just learning to recognize the category. Thyroiditis refers to inflammatory disorders of the thyroid gland. The key word here is inflammatory. This is not a neoplastic process, and it's not just hormone imbalance for no reason. Something is actively damaging the gland. Clinically, thyroiditis often results in hypothyroidism, but many patients go through a temporary hyperthyroid phase first. That happens when inflamed follicles rupture and release stored thyroid hormone. Once those follicles are damaged and the hormone supply is gone, patients swing into hypothyroidism. So hyper first, hypo later. Not always, but often. Two major forms we'll focus on in this course is Hashimoto thyroiditis. This is an autoimmune chronic process and the most common cause of hypothyroiditis in the United States. Over time, immune-mediated follicular destruction leads to permanent hormone deficiency. Subacute granulomatous thyroiditis, or de Quervain syndrome, is typically post-viral, painful, and self-limited. Hormone abnormalities are usually temporary, and most patients recover thyroid function. From a histology standpoint, these entities are very different. Hashimoto shows lymphocyte-driven inflammation. Subacute thyroiditis shows granulomatous inflammation with giant cells. And that difference is exactly why histology matters here. Thyroiditis equals inflammation of the thyroid, often affecting hormone levels, and histology is what distinguishes the type. We'll unpack the specific features on the next few slides. Now let's zoom in on Hashimoto thyroiditis, which you should immediately associate with chronic autoimmune hypothyroidism. This is the most common cause of hypothyroidism in the United States, and unlike some thyroid disorders that come and go, Hashimoto is a progressive, permanent process. Once the immune system decides the thyroid is the enemy, it does not back down. At the core of Hashimoto is immune-mediated destruction of thyroid follicles. Lymphocytes infiltrate the gland, attack follicular cells, and slowly dismantle the normal architecture. As more follicles are destroyed, thyroid hormone production drops, hence the gradual slide into hypothyroidism. Clinically, patients often present early with a goiter. That enlargement isn't because the gland is working harder, it's because it's inflamed and infiltrated. Over time, as follicles are lost, the gland may actually shrink and become fibrotic. Some key histological features, and this is where we earn our paycheck. On histology, Hashimoto's has a very recognizable pattern. Diffuse lymphocytic infiltration throughout the thyroid. This is not subtle. If you see lots of lymphocytes in thyroid tissue, your brain should already be whispering Hashimoto. Lymphoid follicles with germinal centers. Germinal centers do not belong in the thyroid. Their presence tells you this is a true autoimmune process. Follicular atrophy and architectural destruction. Normal, round, colloid-filled follicles get replaced by inflammation and scarring. And then we have these Hürthle or oncocytic cells. These are enlarged epithelial cells with abundant eosinophilic granular cytoplasm due to mitochondrial overload. Fun fact, Hürthle cells are basically the thyroid's way of saying, I am stressed and I have been stressed for a long time. From a lab perspective, Hashimoto is not neoplastic, but it can mimic neoplasia grossly and microscopically if you're not careful. The diagnosis relies heavily on pattern recognition, good fixation, and clean sectioning so lymphoid infiltrates and germinal centers are obvious. Poor fixation can make lymphocytes look muddy and blur the architecture, which makes everyone unhappy, especially the pathologist. So big takeaway here, Hashimoto thyroiditis is chronic, it's autoimmune, it's inflammatory, and it's progressive. And histology is often what confirms the story the labs and symptoms are already telling us. All right, this slide is where we put our histology goggles on and actually use our training. On the right, you're looking at a normal thyroid. This is your baseline, your control slide, your nothing is wrong here thyroid. What should jump out immediately are those round, well-organized follicles, the uniform size and shape. The follicles are filled with a smooth, homogeneous eosinophilic colloid, a thin, orderly layer of follicular epithelial cells, and very little stroma and no inflammatory infiltrate. This is what a thyroid looks like when it's minding its business and producing hormones like it's supposed to. Now shift your eyes to the left. This is Hashimoto thyroiditis, and it should feel visually busy. Instead of nice follicles, you see dense lymphocytic infiltration throughout the gland. Lymphoid follicles with germinal centers. Again, these absolutely do not belong in normal thyroid tissue. We have loss of normal follicular architecture. There are areas where follicles are atrophic, distorted, or completely gone. If the normal thyroid is a neat box of donuts, Hashimoto's is what happens when the donuts get replaced by a lymph node. Zooming in, the little insert highlighting Hürthle or oncocytic cells is important. These cells are enlarged, have abundant eosinophilic granular cytoplasm. They contain lots of mitochondria because of chronic cellular stress. A histology fun fact, Hürthle cells don't mean cancer. They mean the thyroid has been under long-term immune attack. Chronic injury changes how cells look long before it turns into anything neoplastic. From a technical standpoint, this slide reinforces a few key things. Normal versus abnormal thyroid is about pattern, not just individual cells. Hashimoto's is diffuse, not focal. Germinal centers equals autoimmune until proven otherwise. Good fixation and section thickness matter. Lymphocytes get ugly fast when tissue processing is sloppy. If you can confidently say this does not look like normal thyroid architecture, you're already halfway to the diagnosis. So normal thyroid, we have, again, organized follicles and colloid and minimal background noise. Hashimoto's, we have the inflammation replaces the architecture. Histology doesn't just support the diagnosis, it often makes the diagnosis. This is exactly why histology matters in endocrine disease. Labs tell the story biochemically, but we prove it structurally. This is a favorite because it behaves very differently from Hashimoto's, so clinically and histologically. First big point, this is not autoimmune. I'll say that again because someone will try to make it Hashimoto in their head. Not autoimmune. Subacute granulomatous thyroiditis often shows up after a viral upper respiratory infection. The exact cause is unknown. The timeline is suspicious enough that viruses are the usual suspect. The hallmark feature, and this is huge, is painful, tender thyroid enlargement. Patients often have fever, malaise, and neck pain that can radiate to the jaw or ears. That pain alone should make you stop and say, okay, this is not Hashimoto. Hashimoto is many things, but it is not painful. Why hyperthyroid temporarily? Patients often have transient hyperthyroidism, but not because the gland is overproducing hormone. Instead, inflammation destroys these follicles. Preformed thyroid hormone leaks out into the circulation. Think of it like popping open stored hormone cans. No new production, just spillage. This is why it peaks, calms down, and usually resolves on its own in 6 to 8 weeks. There's no long-term autoimmune destruction here. So histology-wise, this is where pattern recognition really matters. What you should see is granulomatous inflammation, multinucleated giant cells surrounding disrupted colloid, and patchy follicular destruction, a mixed inflammatory infiltrate. Those giant cells clustering around damaged follicles are classic. This is your de Quervain fingerprint. What you should not see is, which is equally as important, is what's missing is there's no lymphoid follicles and no germinal centers. That absence is critical. If you see germinal centers, you've drifted back into Hashimoto territory. From a lab and practical standpoint, the inflammation is patchy, so section quality and sampling matter. Giant cells can be subtle. Don't overscan at low power and miss them. This is a true inflammatory process, not chronic immune remodeling. If Hashimoto's looks like a lymph node invaded the thyroid, de Quervain looks like the thyroid is actively under attack, briefly and angrily. So painful thyroid, automatically think acute granulomatous. Then you might see giant cells and disrupted colloid, which gives us de Quervain. No germinal centers, not Hashimoto's. De Quervain is a self-limited process. It usually resolves. And this slide is a perfect example of how clinical presentation and histology together tell the real story. Neither works well alone, but together they kind of bring us full circle. Let's pause here. This is an important vocabulary and mindset slide. It's a description. All goiter means is an enlargement of the thyroid gland. Full stop. That's it. That enlargement can happen when thyroid hormone levels are normal, low, or high. So if you hear goiter and immediately think hypothyroid, that's only sometimes true. So most common cause, of a goiter is iodine deficiency. Globally, the most common cause of goiter, again, is the iodine deficiency. Without iodine, you can't synthesize enough T3 and T4, so low T3, T4 leads to increased TSH. TSH does what TSH does best. It stimulates growth. So think of TSH as the thyroid's personal trainer that never stops yelling, grow, grow, grow. The gland responds by getting bigger, even if hormone production never fully catches up. Here's the sequence you should always walk through. Decreased T3 and T4, you have increased TSH. TSH stimulates follicular epithelial hyperplasia. The result is gland enlargement. This is a reactive process, not a mutation-driven one. Histologically, goiters are variable, and that variability is key. Some common findings include enlarged follicles, hyperplastic follicular epithelium, and uneven or variable colloid content. Some follicles look distended and lazy, others look crowded and busy. The gland is responding unevenly to chronic stimulation. This is why multinodular goiters can form over time. Clinically and grossly, goiters are often described as diffuse with uniform enlargement, single nodule or multinodular, but histologically, remember, this is still reactive hyperplasia, not cancer. This is the line you should hear in your head during any practicals or clinicals or anything like that. Goiter is TSH-driven reactive enlargement, not a neoplasm. Big does not equal malignant, okay? Enlarged does not equal autonomous growth. Always ask why the gland is being stimulated. From a lab perspective, sectioning can be tricky in multinodular goiters due to variable architecture. Colloid consistency can vary, and so fixation quality matters. Pattern recognition beats memorization here. If it looks chaotic but still follicular, think reactive, not malignant. All right, now we're shifting gears from inflammation and functional disorders into thyroid neoplasms. This is where things start to matter a lot from both a diagnostic and histology standpoint. When we talk about thyroid neoplasms, we're really talking about abnormal growths arising from thyroid tissue, and these range from very well-behaved to very not well-behaved. Think of this slide as the table of contents for what's coming next. Broadly, these tumors originate from two main cell populations. You have the follicular epithelial cells, which gives us adenomas, papillary carcinoma, follicular carcinoma, and anaplastic carcinoma. And then parafollicular C cells, which gives us medullary carcinoma. Same organ, very different personalities. On the benign end of the spectrum, we have thyroid adenomas. These are typically encapsulated, non-invasive, and often found incidentally. They may cause a nodule, but they're not trying to take over the world. On the malignant side, we'll be spending time on papillary carcinoma, which is by far the most common thyroid cancer, and honestly, one of the most histology-friendly malignancies you'll ever meet. Lots of classic nuclear features we'll nerd out over shortly. Follicular carcinoma looks deceptively similar to adenoma at low power, and that's where histology becomes critical because invasion, not architecture alone, is the deciding factor. Anaplastic carcinoma is the complete opposite end of the spectrum. This is rare, aggressive, poorly differentiated, and basically the thyroid saying, I have chosen chaos. And then there's medullary carcinoma, which stands apart because it doesn't arise from follicular cells at all. Different cell of origin, different markers, different clinical implications, and we'll absolutely unpack them on their own slide. One important clinical pearl to tuck away is that thyroid nodules are more concerning when they're solitary and when they occur in younger patients. That doesn't mean every nodule is malignant, but it does mean we pay closer attention. From a histotechnology perspective, this section is where good fixation, careful sectioning, and pattern recognition become everything. Many of these entities don't declare themselves loudly. You have to see the subtle differences. So for now, this slide is just your roadmap. Each of these neoplasms gets its own spotlight next, and we'll slow way down once we get into the diagnostic details. Okay, now we're starting our deep dive into the thyroid neoplasms, and we're beginning with the most polite member of the group, thyroid adenoma. A thyroid adenoma is a benign, encapsulated neoplasm arising from follicular epithelial cells. And right away, the word encapsulated should make your histotech brain perk up, because the capsule is about to become the star of the show. Clinically, adenomas are tricky. On imaging and fine needle aspiration, they can look identical to follicular carcinoma. Why? Because FNA and imaging cannot assess capsular or vascular invasion. They can tell you what the cells look like, but they cannot tell you what those cells are doing. And that's the key concept here. The difference between adenoma and carcinoma is behavior, not appearance. Because of this uncertainty, management is usually surgical excision. Not because we think it's malignant, but because we need the entire lesion and capsule to make that call. This is one of those diagnoses where histology doesn't just help, it actually decides. Histologically, adenomas are well-circumscribed nodules with a prominent fibrous capsule. You often see compression of the surrounding normal thyroid parenchyma, which gives that classic pushed-aside appearance. Think of it like a well-behaved house guest who's still rearranged your furniture. The most important negative finding, and yes, negative findings matter, is that there is no capsular invasion and no vascular invasion. None. Zero. If tumor cells cross the capsule or invade vessels, we are no longer in adenoma territory. This is why good tissue handling is absolutely critical. Overfixation, underfixation, thick sections, or chatter can make capsule evaluation difficult and can directly impact diagnosis. This is a slide where histotechnology quality truly matters. So the key takeaway here is almost philosophical. Thyroid adenoma is diagnosed by what it does not do. It does not invade, it does not infiltrate, it stays in its lane. As we move forward, keep this image in your head, because when we get to follicular carcinoma, the architecture may look similar, but the behavior will tell a very different story. All right, now we're moving into the most common malignant tumor of the thyroid, papillary carcinoma. And if there's one thyroid cancer you absolutely want to recognize on sight, this is it. The good news first, papillary carcinoma is usually slow growing and has an excellent prognosis, even though it's malignant. So this is one of those cancers that sounds scary clinically, but histologically it's actually kind of friendly, or as cancers go anyway. What makes papillary carcinoma unique is that the diagnosis is based on nuclear features, not invasion. That is a huge contrast from follicular carcinoma and adenoma, where we are obsessing over capsules and blood vessels. Here, the nucleus tells the whole story. The classic feature you'll hear over and over again is the orphan Annie eye nucleus. These nuclei look optically clear because the chromatin is dispersed and pushed to the periphery. Pathology folklore says that they look like the eyes of the little orphan Annie cartoon character. But if you don't know that reference, just remember, empty-looking nuclei are suspicious. Along with that, you often see nuclear grooves, which are longitudinal folds in the nuclear membrane. I like to tell students they look like someone dragged a fingernail across the nucleus. Hence the classic coffee bean appearance. Once you see it, you can't unsee it. Another feature you may see, but don't have to see, is the posoma bodies. These are lamellated calcifications, basically little concentric mineral donuts sitting in the tissue. They are not required for diagnosis, but if you spot them, they're a strong supporting clue. When it comes to spread, papillary carcinoma prefers the lymphatic system, especially to the cervical lymph nodes. So hematogenous spread is relatively uncommon, which again contributes to its general favorable prognosis. Treatment usually involves surgical excision, often followed by radioactive iodine therapy, depending on staging and risk factors. Because these tumors arise from follicular cells, they retain iodine uptake, something we take full advantage of therapeutically. The key takeaway here is critical for histotechs and pathologists alike. Papillary carcinoma is diagnosed by nuclear detail. That means your fixation, your processing, section thickness, and staining quality really matter. Poor nuclear detail can obscure grooves and clearing, and that can complicate diagnosis. So if follicular lesions taught us to respect the capsule, papillary carcinoma teaches us to respect the nucleus. Different rules, same gland. Now we're moving into follicular carcinoma, and this is where thyroid really starts playing mind games with us. Follicular carcinoma accounts for about 10% of thyroid malignancies, and you'll tend to see it more often in older adults and in regions with iodine deficiency. Grossly and microscopically, it can look very similar to a follicular adenoma, and that's exactly why it's tricky. The single most important diagnostic feature of follicular carcinoma is capsular and/or vascular invasion, not atypia, not nuclear clearing, not architecture, invasion, or it didn't happen. This is a great moment to remind you all why FNA has limitations. So fine needle aspiration can tell you this is a follicular neoplasm, but it cannot tell you whether it's benign or malignant because cytology alone cannot assess invasion. You need the whole capsule. That's why these lesions almost always end up surgically resected. Microscopically, follicular carcinoma forms follicles that closely resemble normal thyroid tissue. And importantly, you do not see papillary nuclear features here, so no orphan Annie eyes, no nuclear grooves. If you do, you should be thinking papillary carcinoma instead. The diagnosis depends on complete microscopic evaluation of the capsule, often requiring multiple levels and careful examination. One tiny tongue of tumor breaking through the capsule or sneaking into a vessel flips the diagnosis from adenoma to carcinoma. That's a lot of responsibility resting on a few microns of tissue. When follicular carcinoma spreads, it prefers the hematogenous route, unlike papillary carcinoma. That means common metastatic sites include bone, liver, and lung. Lymphatic spread is less common here, which is another useful contrast point between these two cancers. From a histotechnology standpoint, this is a great example of why grossing technique, sampling strategy, fixation quality, and sectioning consistency matter so much. If the capsule isn't well sampled or the sections aren't optimal, invasion can be missed, and that changes patient management entirely. The big takeaway for follicular carcinoma is this. It's not about what the cells look like, it's about what they do. If they invade, it's carcinoma. If they don't, it's adenoma. Same cells, just very different consequences. Now we're at the one thyroid tumor that nobody wants to meet in real life, anaplastic carcinoma. This is a rare but extremely aggressive thyroid cancer, and it is the least common of the thyroid carcinomas, but it absolutely punches above its weight. When anaplastic carcinoma shows up, it does not whisper. It kicks the door down. Clinically, patients often present with a rapidly enlarging neck mass, and when I say rapid, I mean weeks, not years. This tumor has a strong tendency for early invasion into surrounding neck structures, which is why patients may develop airway compromise or difficulty swallowing very quickly. This is often a medical emergency, not just an oncology consult. Prognosis-wise, and there's no sugarcoating this, anaplastic carcinoma is almost universally fatal. Survival is typically measured in months, not years. Treatment is usually palliative, and radioactive iodine has no role here because the tumor cells are no longer differentiated enough to take it up. Histologically, this tumor looks exactly like what you'd expect from something that has completely lost control. You'll see marked pleomorphism, meaning extreme variation in cell size and shape. There are spindle cells, giant cells, and often sheets of frankly ugly, disorganized cells. Mitotic figures are everywhere and not polite ones. You'll also commonly see tumor necrosis, reflecting how fast the tumor is growing compared to its blood supply. And here's the key histologic concept. There is no normal thyroid architecture left. No follicles, no colloid, no differentiation. This is what complete dedifferentiation looks like. From a histotechnology perspective, this is one of those cases where pattern recognition is immediate. You're not hunting for subtle, capsular invasion or nuclear grooves. The slide practically announces itself. That said, good fixation and section quality still matter, especially if immunohistochemistry is being used to confirm thyroid origin or rule out metastatic disease. The big takeaway for anaplastic carcinoma is this. This represents total loss of thyroid structure and function. It's the end stage of thyroid malignancy, often arising from pre-existing differentiated cancers like papillary or follicular carcinoma that have accumulated additional mutations over time. If papillary carcinoma is the polite overachiever of thyroid cancers, anaplastic carcinoma is the chaos goblin, and unfortunately, it wins fast. Let's finish our tour of thyroid malignancies with one that is very different from everything we've talked about so far. Medullary carcinoma. Medullary carcinoma is a neuroendocrine tumor of the thyroid, and the first key thing to remember is that it does not arise from follicular cells. Instead, it comes from the parafollicular or C cells, the cells responsible for producing calcitonin. Because of that, medullary carcinoma behaves differently, looks different histologically, and even uses different tumor markers than papillary or follicular carcinomas. Functionally, these tumors secrete calcitonin, and elevated calcitonin levels are used as a tumor marker for diagnosis and follow-up. Interestingly, despite producing calcitonin, serum calcium levels are usually normal, which is a great reminder that hormones don't always behave clinically the way we expect them to on paper. Genetically, this tumor matters a lot. Medullary carcinoma can be sporadic, but it is also classically associated with MEN2 syndromes due to mutations in the RET proto-oncogene. This is why identifying medullary carcinoma has implications beyond the patient. It can trigger genetic counseling and family screening. Now let's talk histology, because this is where medullary carcinoma really earns its keep in the histology lab. Microscopically, you'll see nests or sheets of tumor cells rather than follicles. These cells often have a neuroendocrine appearance, with nuclei showing that classic salt and pepper chromatin pattern. If you've looked at carcinoid tumors or other neuroendocrine neoplasms, this should feel familiar. The signature feature here, and the one everybody absolutely loves, is amyloid deposition in the stroma. This amyloid is derived from altered calcitonin peptides, not immunoglobulins. On H&E, amyloid appears as amorphous pink extracellular material. And when you hit it with Congo red, you get that beautiful apple green birefringence under polarized light, which, let's be honest, is one of the most satisfying things microscopy has to offer. From a histotechnology standpoint, this is a great reminder of why special stains still matter. Proper fixation, section thickness, and polarization technique are critical to demonstrating amyloid correctly. A poorly done Congo red can absolutely sabotage this diagnosis. Prognostically, medullary carcinoma falls in the middle of the pack. It's more aggressive than papillary carcinoma, but far less aggressive than anaplastic carcinoma. 5-year survival is roughly 50%, though outcomes depend heavily on stage at diagnosis and whether the tumor is sporadic or MEN associated. Key takeaway here is this. Medullary carcinoma is a neuroendocrine tumor with amyloid, not follicles, not colloid, not iodine uptake. Different cell of origin, different biology, therefore different rules. If papillary carcinoma is all about nuclei and follicular carcinoma is all about invasion, medullary carcinoma is all about amyloid and calcitonin. We're officially leaving the thyroid behind and heading north, anatomically and conceptually, to the adrenal glands. The adrenal glands sit like little hats on top of the kidneys, and despite their relatively small size, they punch way above their weight in terms of physiologic importance. Stress response, metabolism, blood pressure, electrolytes, all roads lead through the adrenals at some point. Structurally, the adrenal gland is divided into two functionally and embryologically distinct parts. The cortex on the outside and the medulla in the center. Think of it as a gland within a gland situation. The adrenal cortex is mesoderm derived and is responsible for producing steroid hormones, while the medulla is neural crest derived and functions more like modified sympathetic ganglion, producing the catecholamines. Histologically, this makes the adrenal gland one of the nicest teaching organs because the zones are beautifully organized, when they're normal at least. Starting from the outside and moving inward, the cortex is divided into 3 zones. And yes, this is where your favorite mnemonic comes in. GFR. Salt, sugar, sex. The zona glomerulosa sits just beneath the capsule and produces the mineralocorticoids, primarily aldosterone, which regulates sodium and potassium balance and therefore blood sugar. Beneath that is the zona fasciculata, the thickest layer, made up of long cords of lipid-rich cells. This zone produces the glucocorticoids, mainly cortisol, which plays a huge role in metabolism and the stress response. Histologically, these cells look pale and foamy because lipids don't survive routine processing. Classic histotech trivia moment here. The inner cortical layer is the zona reticularis, which produces androgens. It tends to look darker and more compact than the fasciculata due to less lipid content. At the center, we reach the adrenal medulla, which produces epinephrine and norepinephrine. Histologically, this region lacks the neat zonations of the cortex and instead contains clusters of chromaffin cells surrounding a large central vein, a structure you'll often use as your landmark when orienting renal sections. From a histotechnology perspective, adrenal tissue is a great example of why orientation, thickness, and fixation matter. Poor orientation can make the cortex look disorganized, and overprocessing can collapse the delicate architecture between zones. Pathologically, most adrenal diseases are zone-specific, meaning the clinical presentation depends on which layer is affected. Hyperplasia, atrophy, adenomas, and carcinomas often respect or disrupt these zones in predictable ways, which is exactly what we'll start unpacking next. So for now, the big takeaway is this. The adrenal gland is structurally elegant, functionally complex, and histologically layered with purpose. If you know the zones, you already know half the pathology. And yes, if the cortex goes bad, hormones disappear or explode. If the medulla goes bad, blood pressure does weird, dramatic things. Now that we know where the adrenal gland is and how it's built, let's zoom in on the real workhorse, the adrenal cortex. The adrenal cortex produces 3 major classes of steroid hormones, and these hormones are absolutely essential for staying alive under normal conditions, and especially under stress. When the cortex fails, things go downhill fast, and usually dramatically. From a histology standpoint, this is one of those rare organs where structure and function line up beautifully. Each cortical zone makes a specific hormone class, and the microscopic appearance gives you clues about what the zone is doing. First up, we have the glucocorticoids, primarily cortisol, produced by the zona fasciculata. Cortisol regulates glucose metabolism, modulates inflammation, and helps the body respond to stress. If cortisol didn't exist, the phrase fight or flight would be more like panic and collapse. Histologically, the zona fasciculata is the thickest cortical layer and is made of large, pale, lipid-rich cells arranged in long, straight cords. Those empty-looking cytoplasmic spaces you see on H&E, that's lipid that was there before processing. Classic adrenal histology trivia and always a favorite exam clue. Next we have mineralocorticoids, mainly aldosterone, produced by the zona glomerulosa. Aldosterone controls sodium and potassium balance, which means it directly affects blood volume and blood pressure. In other words, this tiny layer has a huge impact on whether your patient is upright or face down. Histologically, the zona granulosa is thicker and more compact, with cells arranged in small rounded clusters or arcs, hence the name glomerulosa. Finally, the innermost cortical layer is the zona reticularis, which produces androgens such as DHEA. These are relatively weak on their own, but can be converted into estrogen or testosterone in peripheral tissues. The zona reticularis tends to look darker and more densely packed than the fasciculata because it contains less lipid, another helpful histological distinction when you're orienting a section. Clinically, the big picture is this. Too much or too little hormone from any one of these zones produces a recognizable disease pattern. Hyperplasia, adenomas, and carcinomas often target specific layers, and your job as a histotechnologist is to preserve the architecture well enough for that story to be read correctly. One important reminder, all of these hormones are steroids, which means they're synthesized from cholesterol. That's why lipid preservation, or rather the lack of it, plays such a big role in how adrenal cortex looks on routine stains. So the key takeaway here is simple but critical. Know the zones, know the hormones, and the pathology will make sense. Now that we understand what the adrenal cortex normally does, this slide is where we start asking the more interesting question: what happens when things go wrong? Disorders of the adrenal cortex are best understood as problems of hormone balance, not just structural abnormalities. These conditions arise when the cortex produces too much or too little of one or more of its steroid hormones, cortisol, aldosterone, or androgens. Broadly speaking, adrenal cortex disorders fall into a few major categories. First is adrenal insufficiency, also known as Addison's disease. This occurs when the adrenal cortex cannot produce adequate corticosteroids. Clinically, patients develop fatigue, weight loss, hypertension, electrolyte imbalances, and an impaired stress response. From a pathology standpoint, this often reflects destruction or atrophy of the cortex, which we'll look at more closely on its own slide. On the opposite end of the spectrum is Cushing syndrome, which represents excessive cortisol. This can result from adrenal tumors, adrenal hyperplasia, or excessive stimulation from ACTH. Clinically, it produces a very recognizable constellation of findings, but histologically, the underlying cause matters greatly, and we'll break that down separately. Another important disorder is primary hyperaldosteronism, also called Conn syndrome. This condition is driven by excess aldosterone production, usually from an adrenal adenoma or hyperplasia of the zona glomerulosa. The key clinical consequences are hypertension and hypokalemia. You'll also notice adrenal hyperplasia listed here. Hyperplasia can be diffuse or nodular and often reflects chronic hormonal stimulation rather than a true neoplasm. It's an important concept because hyperplasia and adenoma can look similarly grossly, but have very different implications. Finally, adrenal tumors form a broad category that includes both benign and malignant neoplasms, some of which are hormonally active and others that are discovered incidentally. As histotechnologists, our role in these cases is critical, especially when evaluating architecture, capsular integrity, and zonal involvement. The key takeaway from this slide is this: adrenal cortex disorders are best characterized by which hormone is affected and why. Once you know the hormone excess or deficiency, the anatomy and histology usually fall into place. Think of this slide as your roadmap. Each of these conditions will now get its own dedicated slide where we'll connect clinical presentation, hormone physiology, and histologic appearance, one disorder at a time. Slide introduces Cushing syndrome, which is one of the most important adrenal cortex disorders to understand conceptually. At its core, Cushing syndrome simply means chronic excess cortisol in the bloodstream. The key word here is syndrome because it describes a clinical state, not a single disease or cause. There are several ways a patient can end up with too much cortisol, and that's where the causes listed here come in. The most common endogenous cause is an ACTH secreting pituitary adenoma, which is specifically called Cushing disease. In this situation, the pituitary is overstimulating the adrenal cortex, leading to bilateral adrenal hyperplasia. Cushing syndrome can also arise directly from the adrenal gland itself, most commonly due to an adrenocortical adenoma, and less commonly from an adrenocortical carcinoma. Importantly, the most common cause overall in real clinical practice is actually iatrogenic, prolonged use of exogenous glucocorticoids. Even though it isn't a primary adrenal disease, it still produces the same clinical features because cortisol levels are elevated. Clinically, Cushing syndrome has a very characteristic presentation. Excess cortisol redistributes fat centrally, giving rise to truncal obesity, moon face, and the classic buffalo hump. Cortisol also antagonizes insulin and promotes gluconeogenesis, which is why these patients commonly develop hyperglycemia and secondary diabetes, along with hypertension. From a tissue standpoint, cortisol is catabolic, so patients develop muscle weakness, thin skin, and easy bruising due to protein breakdown and impaired collagen synthesis. Now, from a pathology perspective, what's important for us is this. The adrenal cortex itself may show hyperplasia or neoplasia depending on the source of cortisol excess. These changes are driven by hormone stimulation, not inflammation. So when you're evaluating adrenal tissue in a suspected Cushing patient, you're looking for architectural changes, not inflammatory infiltrates. The big takeaway from this slide is a conceptual one. Cushing syndrome refers to cortisol excess regardless of where it comes from. This slide introduces primary hyperaldosteronism, also known as Conn syndrome, which is another important disorder of the adrenal cortex, specifically the zona glomerulosa. At its core, primary hyperaldosteronism refers to chronic excess production of aldosterone by the adrenal gland itself. The word primary is key here. It tells us the problem originates within the adrenal cortex, not from upstream stimulation like the renin-angiotensin system. The two most common causes are listed here: an adrenocortical adenoma, which is usually unilaterally, and adrenocortical hyperplasia, which is often bilateral. Aldosterone's normal job is to regulate sodium and potassium balance in the kidneys. When too much aldosterone is produced, that normal regulation goes into overdrive. Excess aldosterone causes increased sodium retention, and because water follows sodium, this leads to expanded blood volume. At the same time, aldosterone promotes potassium excretion, which can drive potassium levels dangerously low. Clinically, this combination produces the hallmark features of Conn syndrome. Patients develop hypertension, which is often resistant to standard treatment. This is a classic clinical clue. The potassium loss leads to hypokalemia, which explains symptoms like muscle weakness, fatigue, and sometimes muscle cramps or arrhythmias. From a pathology perspective, the important thing to recognize is that this disorder reflects hormone overproduction, not inflammation or immune-mediated injury. The structural changes occur in the zona glomerulosa, either as nodular hyperplasia or as a discrete adenoma, depending on the underlying cause. So when you're evaluating adrenal tissue in this context, you're thinking in terms of architecture and hormone output, not inflammatory infiltrates or necrosis. The big takeaway from this slide is this: primary hypoaldosteronism is a volume-driven hypertension disorder caused by autonomous aldosterone secretion from the adrenal cortex. Slide introduces adrenocortical failure, also called adrenal insufficiency, which represents the opposite physiological problem from the disorders that we've previously discussed. Instead of hormone excess, this condition is defined by inadequate production of adrenocortical hormones due to dysfunction or destruction of the adrenal cortex. Clinically, adrenal insufficiency can present in two primary forms. We have primary acute adrenocortical failure, often referred to as adrenal crisis, and it is a medical emergency. Or we have primary chronic adrenocortical failure, better known as Addison's disease, which develops more gradually and is the form most often encountered in long-term pathology discussions. A key concept here is that all three classes of adrenocortical hormones are deficient in primary adrenal insufficiency. This includes glucocorticoids, mineralocorticoids, and androgens. From a clinical standpoint, the most important deficiencies are cortisol and aldosterone. Again, loss of cortisol results in an impaired stress response and can lead to hypoglycemia, especially during illness or physiological stress. Loss of aldosterone causes sodium loss and potassium retention, which leads to hypotension, dehydration, and electrolyte imbalances. The most common underlying cause of primary adrenal insufficiency is autoimmune destruction of the adrenal cortex. Other causes include infection, hemorrhage, or metastatic disease, all of which physically damage adrenal tissue. Clinically, patients often present with hypotension, dehydration, hyponatremia, and hyperkalemia. They also commonly report fatigue, weakness, and weight loss, reflecting both metabolic disruption and volume depletion. From a pathology perspective, adrenal insufficiency reflects loss or destruction of functional adrenal cortex rather than hormone dysregulation alone. Over time, this leads to adrenal atrophy, which may be appreciated grossly or microscopically depending on the underlying cause. The key takeaway from this slide is that primary adrenal insufficiency is a hormone deficiency state caused by structural damage to the adrenal cortex, not a problem of pituitary signaling or adrenal overstimulation. This slide focuses on a primary acute adrenocortical failure, also known as the acute adrenal crisis. Unlike chronic adrenal insufficiency, this is a sudden, life-threatening emergency. The key concept to anchor here is onset. Acute adrenal crisis develops rapidly, often without warning, and requires immediate recognition and treatment. One of the classic causes is bilateral adrenal hemorrhage, which can occur in the setting of sepsis, particularly in the Waterhouse-Friderichsen syndrome. In this scenario, overwhelming infection leads to vascular collapse and hemorrhagic destruction of both adrenal glands. Another important cause is severe physiologic stress, such as trauma, surgery, or infection, in a patient with undiagnosed or poorly controlled Addison's disease. These patients simply cannot mount an adequate cortisol response to stress. From a hormonal standpoint, both cortisol and aldosterone levels drop abruptly. This combined loss is what makes adrenal crisis so dangerous. Clinically, patients present with severe hypotension that can progress to shock. Hypoglycemia is common due to cortisol deficiency, and electrolyte disturbances include hyponatremia and hyperkalemia, reflecting aldosterone loss. From a histologic and gross pathology perspective, the adrenal glands show acute hemorrhage and necrosis of the adrenal cortex. This is not a slow degenerative process. It is rapid tissue destruction. The gross images on this slide highlight how dramatic this damage can be, with dark hemorrhagic adrenal tissue replacing normal cortical architecture. The most important takeaway from this slide is simple and high yield. Acute adrenal crisis is a medical emergency. Without prompt treatment, including corticosteroid replacement and supportive care, it can be fatal. As pathologists and histotechnologists, recognizing the underlying mechanisms helps us connect sudden clinical collapse with adrenal pathology, particularly in cases involving sepsis, hemorrhage, or unexplained shock. This slide focuses on primary chronic adrenocortical failure, more commonly known as Addison's disease. The most important contrast to make here is with the previous slide. This process is gradual and progressive, not sudden. Addison's disease develops over time as the adrenal cortex is slowly destroyed. Patients often experience symptoms for months or even years before a diagnosis is made. The most common cause is autoimmune adrenalitis, accounting for the majority of cases in developed countries. In this process, autoantibodies target adrenocortical tissue, leading to chronic inflammation and eventual atrophy. Less common causes include infections such as tuberculosis or HIV and metastatic cancer involving the adrenal glands. From a hormonal perspective, this is a deficiency of all three adrenocortical hormones: cortisol, aldosterone, and androgens. Clinically, cortisol deficiency leads to fatigue, weight loss, and poor stress intolerance. Aldosterone loss causes chronic hypotension, along with hyponatremia and hyperkalemia. One of the classic features of Addison's disease is hyperpigmentation. This occurs because low cortisol levels trigger increased ACTH production, and ACTH is derived from POMC, which also increases melanocyte-stimulating hormone. As a result, patients develop diffuse skin darkening, particularly in sun-exposed areas, skin creases, and mucous membranes. Histologically, the adrenal glands show cortical atrophy with chronic inflammatory infiltrates. Over time, functional adrenal tissue is lost and replaced by fibrosis or lymphocytic inflammation. Unlike acute adrenal crisis, this is not immediately fatal, but it is progressive and irreversible without lifelong hormone replacement. Final takeaway for this slide is that Addison's disease represents slow, permanent destruction of the adrenal cortex, and patients are at constant risk of developing an acute adrenal crisis during times of stress if not properly managed. Together, slides 20 and 21 illustrate the same disease process on two very different timelines, one catastrophic and immediate, the other insidious and chronic. So on this slide, we're introducing pheochromocytomas, which are neoplasms of the adrenal medulla arising from chromaffin cells, and in my opinion, one of the funnest words to say. These tumors are important because while they are often histologically benign, they can be clinically dangerous due to hormone secretion. Pheochromocytomas are the most common tumor of the adrenal medulla, and they produce excess catecholamines, primarily epinephrine and norepinephrine. The excess catecholamines explain the classic clinical presentation. Patients may have episodic or sustained hypertension, along with the classic triad of headache, palpitations, and sweating. These symptoms are often paroxysmal, meaning they come and go, which can make diagnosis challenging and sometimes delayed. Pheochromocytomas may occur sporadically, but a significant subset is hereditary. They are associated with genetic syndromes including MEN2, neurofibromatosis type 1, and von Hippel-Lindau disease. From a pathology standpoint, behavior is unpredictable. There are no reliable histologic criteria that definitively distinguish benign from malignant pheochromocytomas. Malignancy is defined by metastasis, not morphology. Histologically, these tumors show a very characteristic pattern called Zellballen, which refers to nests of tumor cells separated by a rich vascular stroma. This nested architecture is a key microscopic clue and something you should be able to recognize on routine H&E sections. Clinically, pheochromocytomas are extremely important because undiagnosed tumors can precipitate life-threatening hypertensive crises, especially during surgery, anesthesia, or stress. That's why identifying and communicating suspicion of a pheochromocytoma is critical. This is a tumor where the diagnosis can literally change perioperative management. The key takeaway here is that pheochromocytomas are medullary tumors with outsized clinical impact, often benign in appearance, hormonally active, genetically associated, and potentially fatal if missed. This slide introduces multiple endocrine neoplasia, or MEN, which refers to a group of inherited syndromes caused by germline gene mutations. The defining feature of MIN is the presence of multiple endocrine tumors in the same patient, either occurring at the same time or developing sequentially over years. These tumors are not limited to one type. Patients can develop adenomas, hyperplasia, or carcinomas depending on the organ involved. A key concept here is distribution. MIN affects more than one endocrine organ, which is very different from sporadic endocrine tumors that usually involve a single gland. Another major clue is age. Tumors associated with MIN tend to occur at a younger age than sporadic endocrine neoplasms. So if you see multiple endocrine lesions in a young patient, MIN should immediately be on your differential. On the right side of the slide, you'll see the classic MIN subtypes. MIN1, which commonly involves the parathyroids, pituitary, and pancreatic endocrine tumors. MIN2A, which is associated with medullary thyroid carcinoma, pheocytomas, and parathyroid disease. MIN2B, which means medullary thyroid carcinoma and pheocytomas, along with distinctive neural findings. From a pathology and histotechnology perspective, MIN matters because finding one endocrine tumor may imply others are present or developing. This has major implications not just for the patient but for family members, since these syndromes are inherited and often require genetic screening and long-term surveillance. The key takeaway is this: MIN is a pattern diagnosis. When endocrine tumors cluster, especially in younger patients, think beyond a single gland and consider a syndromic process. Sorry about that. Now we're shifting to the parathyroid glands, which are small but extremely important regulators of calcium balance. These glands are located on the posterior aspect of the thyroid, but functionally they are completely independent of thyroid hormone. The parathyroid secrete parathyroid hormone, or PTH, whose primary job is to increase serum calcium levels. PTH raises calcium through three coordinated mechanisms. It increases bone resorption, releasing calcium from the skeleton. It increases renal calcium reabsorption, reducing calcium loss in urine. And it increases vitamin D activation, which enhances calcium absorption from the gut. Because of this, parathyroid disorders tend to show up clinically in the bones and kidneys rather than as local neck syndromes. The most common parathyroid pathology is a parathyroid adenoma, which leads to excess PTH production. From a histology standpoint, the parathyroid is composed primarily of chief cells, which actively secrete PTH, oxyphil cells, which are larger eosinophilic cells and less clear functional significance. An important diagnostic principle here is that parathyroid disease is not diagnosed by histology alone. Diagnosis relies heavily on serum calcium and PTH levels, with histology playing a supportive role rather than a definitive one. Key takeaway is this: parathyroid pathology is a hormone-driven disease, and understanding its effects on bone, kidney, and calcium metabolism is far more important than recognizing subtle histologic differences. Now we're putting the thyroid physiology into a disease context with hyperparathyroidism. Hyperparathyroidism simply means excess secretion of parathyroid hormone, or PTH, which disrupts the normal balance between calcium and phosphate in the body. The most common form is primary hyperparathyroidism, and in the majority of cases, this is caused by a parathyroid adenoma. Less commonly, it can result from parathyroid hyperplasia, where multiple glands are overactive. There is also secondary hyperparathyroidism, which is not a primary gland problem. This most often occurs in chronic renal failure, where phosphate retention and impaired vitamin D activation lead to chronically low calcium levels. The parathyroid glands respond by increasing PTH production as compensation. Regardless of the cause, the physiological effects of elevated PTH are consistent. PTH increases bone resorption, releasing calcium into the bone stream. It increases renal calcium reabsorption while promoting phosphate excretion. It increases intestinal calcium absorption indirectly through vitamin D activation. When you add all of this together, the net result, especially in primary hyperthyroidism, is hypercalcemia, hypophosphatemia. Clinically, this explains why patients develop complications involving the bones, kidneys, and the neuromuscular system rather than local neck symptoms. The key takeaway for this slide is that hyperparathyroidism is a systemic metabolic disorder driven by excess PTH and best understood by following where calcium and phosphate move in the body. Let's look at the opposite problem, hypoparathyroidism. Hypoparathyroidism is defined by a deficiency of parathyroid hormone, or PTH. Because PTH is the body's primary regulator of calcium, a lack of PTH leads directly to hypocalcemia and hyperphosphatemia. The most common cause is very practical and very testable: accidental removal or damage to the parathyroid glands during thyroid or neck surgery. This is why hypocalcemia after thyroidectomy is such an important postoperative concern. Other causes include congenital absence, autoimmune destruction, or gland atrophy. These are much less common. When PTH levels are low, all of its normal actions are reduced. Bone resorption of calcium decreases, renal calcium reabsorption decreases, and intestinal calcium absorption decreases. due to reduced vitamin D activation. The net effect is a drop in serum calcium, which explains the clinical picture. Clinically, hypoparathyroidism presents with neuromuscular irritability because calcium stabilizes neuronal membranes. When calcium is low, nerves fire more easily. Patients develop tetany, muscle cramps and spasms, perioral and extremity tingling, also called paresthesis. The key takeaway here is that hypoparathyroidism is not subtle. It produces symptomatic hypocalcemia, often requiring prompt recognition and treatment. From a pathology standpoint, diagnosis is based on low calcium with low or inappropriately normal PTH rather than biopsy. Just an optional teaching moment here. High PTH breaks bones. Low PTH makes nerves twitch. This slide is one I really want you to lock into memory because it shows how calcium levels drive symptoms. On the left, we have hypoparathyroidism, which leads to hypocalcemia. When calcium is low, nerves become overexcitable. That's why hypercalcemia gives us the mnemonic, no calcium gives me cramps, CRAMPS. You'll see muscle spasms and tetany, hyperactive reflexes, arrhythmias, particularly prolonged QT, and perioral and extremity tingling. It's a classic, so things like Trousseau syndrome. The big theme here is neuromuscular irritability. On the right, we have hyperparathyroidism, which causes hypercalcemia. High calcium has almost the opposite effect. It makes nerves and muscles sluggish. This is where the classic phrase comes in: bones, stones, groans, and moans. Bones, bone pain and skeletal changes from increased resorption. Stones is kidney stones, which can progress to renal damage. Groans, we have GI symptoms like nausea, vomiting, and constipation. And then moans, the more neuropsychiatric changes, fatigue, depression, memory issues, even psychosis. The key contrast is this: low calcium equals twitchy nerves, high calcium equals sluggish systems. If you remember that, you can reason through the rest. An optional one-liner is low calcium makes nerves fire, high calcium makes them tired. Okay. That brings us to the end of our endocrine system for HDL302. We covered a lot: hormone regulation, adrenal and parathyroid disorders, how hormone imbalances translate into real clinical findings you'll see in patients in pathology. At this point, I want you focusing less on memorizing lists and more on patterns. So what happens when a hormone is too high? What happens when it's too low? And how the body responds when feedback loops fail. If you have questions now or later, please reach out. Email me, come to office hours, or bring, questions to the discussion posts. That's literally what I'm here for. And remember, these images and examples are here to support your learning, not to overwhelm you. You are not expected to know everything at once. Take a breath, review the big concepts, and trust me, you're doing just fine.